Hey, I'm Jibi nurse practitioner, currently working in Right Focus Healthcare LLC. Regarding my clinical experience, I have 3 years of pulmonary nurse practitioner, 1 year of primary care nurse practitioner, and 18 years of RN. Today we are talking about rhinosinusitis or sinusitis. This video of rhinosinusitis, I'm doing it as a review for primary care nurse practitioners. Due to the concern of antibiotic resistance nowadays, why it's very important for nurse practitioners to know about the classification and clear treatment algorithms available for the diagnosis and treatment for rhinosinusitis. How do we define rhinosinusitis? It is the acute, subacute, or chronic inflammation of the mucous membranes that line the paranasal sinuses and associated inflammation of nasal mucosa per Graham and Uphold clinical guidelines. Please note, rhinosinusitis and sinusitis are same. But because the paranasal sinuses are connected to nasal cavity, the term rhinosinusitis is appropriate. What is the epidemiology of rhinosinusitis? It is extremely common and typically of viral cause, but still it accounts for 30 million primary care visits and 11 billion in healthcare expenditure. It accounts for 1 in 5 prescriptions for antibiotics. Approximately 6 to 7% of children with respiratory symptoms have acute rhinosinusitis. 16% of adults are diagnosed with acute bacterial rhinosinusitis annually. Chronic rhinosinusitis incidence reported at 12.3% in USA, 10.9% in Europe, and 13% in China. Next is classification of acute rhinosinusitis. The classification is very important because the treatment varies. Acute rhinosinusitis, abrupt onset of infection with duration of symptoms less than 4 weeks. Next is subacute rhinosinusitis. It's a persistent occurrence of purulent nasal discharge even after treatment, and the nasal epithelial damage is usually reversible. Minimal to moderate symptoms that last 4 to 12 weeks. Next, chronic rhinosinusitis, prolonged inflammation or repeated or inadequately treated acute infection, and there is irreversible damage to the nasal mucosa, and the symptoms last greater than 12 weeks or 3 months. Recurrent acute rhinosinusitis, 4 or more episodes per year, with each episode at least 7 days in duration, and there is absence of signs and symptoms between episodes. I did not detail the symptoms, as in the next few slides we are going to discuss in detail about the symptoms. Let's do a quick review of anatomy and physiology of paranasal sinuses, which would be useful for nurse practitioner students. Paranasal sinuses are hollow air-filled spaces in the skull and facial bones that surrounding the nose. There are 4 paired paranasal sinuses named based on their location. As you see in the picture, the frontal paranasal sinus is located in the lower forehead. Second one, the ethmoid, between the nose and the eye in the ethmoid bone. Third one, the maxillary, which is the largest of sinuses under the eyes in the cheekbone. The sphenoid one located behind the nose. As you see in the lateral picture, it's near the upper part of the ear. Why the anatomy is important? Because pain in these locations is a major clinical presentation in sinusitis. And in my patients, what I have seen is that they complain of pain mostly when they don't complain, when you palpate them, they feel pain in the frontal and maxillary sinus, majority of them. Let's do a quick review of pathophysiology for NP students. Sinuses function to filter out pollutants, microorganisms, dust, and other antigens. Sinuses drain into the intranasal cavity through small channels called ostia. Also, the cilia lining in the mucous membrane of nasal cavity and nasopharynx, they work together to circulate mucus and filter debris into the nasopharynx or swallowed into the oropharynx. In rhinosinusitis, there is obstruction of the sinus ostia because of the upper respiratory infection or allergic rhinitis or environmental pollutant smoke or deviated septum or neoplasm, foreign body, the obstruction and plus ciliary dysfunction in case of cystic fibrosis, they lead to lower level of oxygen within the sinuses. So, and there is decreased clearance of foreign material, and this mucostasis lead to inflammation and bacterial proliferation. And as you see in the picture, the yellow color, the mucus production, that leads to rhinosinusitis. Etiology of rhinosinusitis. I have already mentioned most of it. Obstruction of sinus ostia due to recent upper respiratory infection, allergic rhinitis, environmental pollutants like smoke, trauma, foreign body, extension of a dental abscess, neoplasms, and medication side effects like hormone replacement sprays or due to abuse of topical decongestants and cocaine, rhinitis medicamentosa, and anatomic abnormalities such as deviated septum, diving or swimming. So, and another one is that the thickening of sinus secretions and ciliary dysfunction in diseases like cystic fibrosis or due to immune deficiency. Now, the pathogens, viruses are more common than bacteria. So that's why we need to know the duration of the symptoms. Streptococcus pneumoniae, there are some penicillin resistance one, and then Haemophilus influenzae, they may be beta-lactamers producing. That's why we need to give antibiotics according to that. Streptococcus pyogenes and fungi are more common in patients who are immunosuppressed or have diabetes. Symptoms of rhinosinusitis and how to diagnose it. First, history. Ask the patients about onset of symptoms, duration of symptoms. Remember, we did the classification less than 12 weeks, 4 to 12 weeks, or greater than 12 weeks, or 3-4 times a year, and the season of the symptoms, and whether the symptoms are improving or worsening, or like a viral upper respiratory infection just got better and then made it worsened after that, and any pain, and describe the pain and what aggravates it, and the quality of the nasal discharge, whether it's mucoid or purulent, and ask about fever and fatigue, cough, postnasal drip, whether the cough is dry or productive, timing of the cough, and the quality of the headache, any morning puffiness, and what time the headache, morning headache. That is only to rule out any other symptoms like a neurology problem. And a question about smoking, any recent trauma to the nose, any upper respiratory infection, any past medical history, allergies, diabetes mellitus, immunodeficiency, asthma, any chronic respiratory complaints. Next, physical examination. Check vital signs, especially temperature, very important. And examine eyes, any periorbital swelling and presence of allergic shiners, and nasal mucosa for erythema, edema, or discharge by a speculum. Examine also check for any presence of polyp, any septal deviation, any other deformities, and ear, nose, and throat, and mouth for signs of inflammation. Examine teeth and gingiva for caries, inflammation. Remember, we discussed about the dental abscess. 10% of maxillary sinusitis is due to dental root infection, and palpate neck and jaw for any lymph nodes, adenopathy. Check the lung sounds, and check if there is any neurological evaluation further needed, any complications. if to rule out any complications. Next is clinical representation of acute bacterial rhinosinusitis. Any of the, as you see in the table, any of those three presentations can identify patients with the acute bacterial rhinosinusitis. Number one, the symptoms or signs lasting for greater than 10 days with no evidence of improvement. What that means, if it is less than 10 days, we can wait, as it could be viral or it could be due to allergic rhinitis. And Number two, the severe symptoms or signs of high fever, like 102 degree or 39 degrees Celsius, and purulent nasal discharge, or the facial pain lasting for at least 3 to 4 consecutive days at the beginning itself. Number three, the patient who had a upper respiratory infection that lasted 5 to 6 days, but was initially improving, but then the symptoms got worsened, and now there is new onset of fever, headache, or increase in the nasal discharge. Other clinical features are facial pain, nasal obstruction, hyposmia or anosmia, which means loss of smell, halitosis or means bad breath, dental pain, cough, ear pain, sore throat, early morning periorbital around the eye, swelling, toothache, malaise, increased pain with the coughing or moving or bending over, or sudden head movement, and there is no response to decongestants. Chronic bacterial sinusitis, what are the criteria to diagnose it? It's number one, the period of duration lasts greater than 12 weeks. The second one, yes, you see in the yellow heading, the signs and symptoms of chronic rhinosinusitis. 2 or more of the following in the first section: mucopurulent drainage, nasal obstruction or congestion, facial pain, pressure, hyposmia or anosmia, which means loss of smell. And one of the criteria in the second section, purulent mucus or edema in the middle meatus or the ethmoid region, and the polyps in the nasal cavity, or X-ray image with the evidence of inflammation of the paranasal sinuses. And for recurrent acute rhinosinusitis, the criteria is that each episode should meet the same diagnostic criteria as acute bacterial rhinosinusitis. Just a word about complications: preseptal cellulitis, orbital cellulitis, subperiosteal abscess, orbital abscess, cavernous sinus thrombosis, which these complications are rare occurrence, but when it occurs, it's serious. So what happens is that when paranasal sinuses are infected and it's not treated, it will spread it to the brain and can cause these serious complications. Why, as a primary care nurse practitioner, it's important to know when to do the referral by seeing what kind of symptoms. In situations like recurrent symptoms, even after treatment in chronic recurrent sinusitis, and extreme pain on palpation of face, periorbital swelling. On cranial nerve exam, we see impaired vision or impaired extraocular mobility. There may be need a CT to rule out complications, so need a ENT or neurology referral appropriate. And uncontrolled asthma, for maybe that's causing the sinusitis, and the respiratory infections that may be causing. So pulmonologist, and severe allergies, therefore the allergy specialist, and as I mentioned, dental caries, so appropriate dental referral. Next is viral rhinosinusitis management. As we discussed, if the duration of the symptoms is less than 10 days or 2 weeks, we only do symptomatic treatment and no antibiotics necessary. There's those symptoms like if there is pain, treat with Tylenol or NSAIDs like ibuprofen. If there is nasal stuffiness and congestion, the decongestants, which reduces swelling and relieve nasal congestion, open airway. The examples are oxymetazoline spray spray 2 to 3 actuation in Q12 hour PRN, and the brands are like Mucinex and Afrin, but we cannot use it longer than, very important, not use longer than 4 days. It can cause vasoconstriction. The oral decongestants are not effective as topical agents, but Sudafed 60 milligram Q4 hour, but we should avoid those in patients with cardiac disease, uncontrolled hypertension, glaucoma, because the same reason it can cause vasoconstriction. Number 3, saline nasal spray, which is 2 to 3 nasal drops in each nostrils PID, which is a very safe one if it is not very allergic. There is no allergy, the symptoms are not severe. Mucolytics like Mucinex 1200 1 tap Q every 12 hour. And then nasal corticosteroid, it's not as recommended as evidence for the rhinosinusitis, but it's very good in allergic rhinitis. 1 to 2 nasal spray in each nostrils QD. Antihistamines not recommended as it is dry out. And then if it is the symptoms are combined with allergy, we want to talk about oral corticosteroids. You can do fexofenadine plus pseudoephedrine combination Allegradi 1 tap QDPRN. And then last but not least, home remedy, a lot of encourage lot of fluids, warm moist compress over the nasal area, and that get plenty of rest. Management of acute bacterial rhinosinusitis, we already discussed the criteria for how to diagnose it. The major one, the symptoms last greater than 10 days. Treatment should start as soon as we diagnose it. The duration of treatment is 5 to 7 days for adults, 10 to 14 days in children. Augmentin 500 to 875 milligram POPID. We already discussed about the pathogens like Haemophilus influenzae produce beta-lactamers. So that's why we have to use the beta-lactamers classification antibiotic. And then remember we discussed about streptopneumoniae, which is a antibiotic resistance in those group. So that's why never not recommended macrolides alone like azithromycin or CPAC or Bactrim. Next case, high dose Augmentin 2 gram twice a day if we note systemic toxicity or fever 102 degree Fahrenheit, or those with recent hospitalization or antibiotic within the past 5 months. But for primary care nurse practitioners, by this time you should consider a referral too, so that underlying any problems we can find out. Then there is number 3, if the patient has a history of penicillin allergy, doxycycline 100 milligram PO PID, Levaquin 500 milligram PO daily. Adjunctive therapy, intranasal corticosteroids like Flonase 1 to 2 nasal sprays on both nostrils Q12 hour. It's especially if the patient has allergic rhinitis. The difference with the rhinosinusitis, we are using the acute viral rhinosinusitis. We are not using topical decongestants, and antihistamines not recommended, and we use antibiotics in bacterial rhinosinusitis. Management of chronic rhinosinusitis and recurrent rhinosinusitis. We already discussed how is the criteria for diagnosis. If it is less than or more than 12 weeks, it's chronic. And then if it is 4 episodes or 3 to 4 episodes within 1 year with no symptoms between the episodes, recurrent. And assess these patients for diseases, underlying disease like allergic rhinitis, cystic fibrosis, or immunocompromised states, or ciliary dysfunction. And treatment with the saline nasal irrigation, we already discussed. Nasal corticosteroids such as Flonase, 2 sprays in each nostril once a day, or 1 spray PID. For exacerbation, treat with 3 to 6 weeks of antibiotic. And oral corticosteroid bust also may be helpful, like prednisone 40, and starting with 40 and tapering it down. And referral is needed for chronic rhinosinusitis who has frequent severe symptoms and frequent exacerbations. For recurrent rhinosinusitis, It's the same, treat with the antibiotics like bacterial rhinosinusitis, and also they may be benefit from steroids or saline nasal spray and decongestants and mucolytics. I already discussed the medication in each class, so not repeating. For bacterial rhinosinusitis, follow up the patient after the treatment order in 2 weeks. For chronic sinusitis, we already discussed the treatment and the referral situations, but there is no improvement of after antibiotics for 4 weeks. Refer to an ENT specialist. A quick review of prevention of rhinosinusitis and patient education during acute symptoms. Educated them about hand washing. Number 2, smoking cessation and avoid secondhand smoking and avoid any allergens. Humidify air and increase fluid intake. And during the period of the symptoms, sleep with the head of bed elevated so there is a smooth passage of air. Then avoid swimming or diving or air travel during the acute symptom period, and teach them about proper application of nasal sprays. There are a lot of videos. Hey, thank you for listening to my video, and I hope it was very helpful for the nurse practitioners and nurse practitioner students. Thank you.